A 2-year-old is brought to your GP clinic. He's got a fever of 38.6 degrees, is constantly pulling at his right ear, and has been irritable and off his food all day. You suspect acute otitis media. But what are the classic signs on otoscopy? Do you give antibiotics or not? And what's the first line choice according to NICE guidelines? By the end of the video, you'll have a clear, simple answer to all those questions and be ready for any UKMLA scenario. So let's start with a solid definition. Acute otitis media is a rapid onset inflammation of the middle ear, which is almost always triggered by an infection. The key word here is acute. We're talking about a sudden onset of symptoms, typically over the last 24 to 48 hours. This is what distinguishes it from its chronic cousin, otitis media with effusion, or glue ear, which we'll cover in another video. Acute otitis media is overwhelmingly a disease of childhood. It's one of the most common reasons for pediatric primary care visits, with a peak incidence between 6 and 18 months of age. It's estimated that up to 80% of children will have at least one episode by the time they are 3. So why is it so common in this age group? This comes down to the risk factors. The key risk factors include age. This is the biggest one, due to anatomy, which we'll get to in a second. Daycare or nursery attendance. This causes children to be exposed to a wider range of viral upper respiratory tract infections. Dummy or pacifier use. Supine bottle feeding. Passive smoking, which can impair mucociliary function. Underlying conditions such as immunodeficiency, gastroesophageal reflux disease, or craniofacial abnormalities such as cleft palate, and finally, formula feeding, as breastfeeding is known to be protective. To understand acute otitis media, you must understand the anatomy. The middle ear is a small air-filled cavity. It's connected to the back of the throat, the nasopharynx, by the eustachian tube. It has 2 crucial jobs. Number 1, ventilation and pressure equalization. It aerates the middle ear to keep the pressure equal with the outside world. This is what pops when you're on a plane. Secondly, drainage. It allows any fluid or mucus to drain from the middle ear down into the pharynx. Under normal circumstances, the middle ear is a sterile environment. So what goes wrong? The pathophysiology almost always starts with a viral upper respiratory tract infection. This virus causes inflammation and edema of the nasopharynx, which includes the opening of the eustachian tube. The tube swells and becomes blocked, and this blockage or eustachian tube dysfunction is far more likely in a child because their tube is shorter, floppier, and more horizontal, which severely impairs drainage. Once blocked, 2 things can happen. Air is absorbed, creating a negative pressure in the middle ear. This is what causes the initial pain. A sterile transudate or fluid is drawn into the middle ear space to fill this vacuum. This stagnant fluid is a perfect, warm, nutrient-rich broth for bacteria. Pathogens from the nasopharynx ascend the eustachian tube and cause a secondary bacterial infection. The big 3 pathogens you must know for exams are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. The pathophysiology leads directly to the classic clinical features. The history is key, especially in a pre-verbal child. Some features can include rapid onset otalgia or ear pain. In a toddler, this can present as ear tugging, rubbing, or holding the ear. Furthermore, there can be fever, which is very common, often 38 degrees Celsius or higher. Systemic upset, the child will be irritable, anorexic, which means off their food, and have disturbed sleep. There will be a preceding upper respiratory tract infection in most cases. The parent will almost always report a recent runny nose or cough. And finally, otorrhea, which is if the pressure from the pus builds high enough, the tympanic membrane will perforate. You'll see discharge from the ear, which is often followed by a sudden relief of pain. The diagnosis of acute otitis media is clinical. You do not need labs or imaging. The single most important investigation is otoscopy. Your findings will be definitive. There will be a bulging tympanic membrane. This is the most important sign. The pressure from the pus pushes the eardrum outwards, making it look like a bulging donut. Erythema, the drum will be diffusely red and injected. Opacification, the drum will be cloudy or opaque, not its normal pearly grey. And finally, there can be a loss of light reflex. The bulging distorts the drum, causing the normal cone of light to disappear. So to officially diagnose acute otitis media, you need 3 things. Number 1, an acute onset of symptoms. Number 2, the presence of a middle ear effusion, which is confirmed by a bulging tympanic membrane or otorrhea. And thirdly, signs of middle ear inflammation, like that distinct erythema we saw on otoscopy. But you must rule out other causes. Your key differentials are otitis externa. Look for a swollen red ear canal. The classic sign is pain on pulling the pinna or pressing the tragus. The tympanic membrane itself might be obscured or normal. Another differential would be otitis media with effusion, otherwise known as glue ear. This is fluid without acute infection. The main symptoms can be hearing loss rather than pain or fever. On otoscopy, the tympanic membrane will be retracted and dull, often with visible air fluid levels, but not red or bulging. And lastly, referred pain. This is a classic trap. Always examine the throat for tonsillitis and the mouth for dental abscesses, as both can present with ear pain. And for management, which is the most important section for your UKMLA, how do we manage acute otitis media? The first principle is admission. Who needs to go to hospital? Well, any child that is systemically very unwell, under 3 months with a fever, over 38 degrees, or if you suspect a complication like mastoiditis, should be sent to hospital. The second principle is symptomatic relief. For everybody else, the management is mostly supportive. The vast majority of acute otitis media cases are self-limiting and resolve in 3 to 4 days. The cornerstone of management is simple analgesia, regular paracetamol and ibuprofen. The third thing that we need to think about is the antibiotic strategy. This is where we use the NICE traffic light system. We don't give antibiotics to most children. We use a delayed prescription strategy. This means you give the parent a prescription, but advise them to only use it if the child's symptoms haven't improved after 3 to 4 days, or if they get significantly worse. So who does get immediate antibiotics? NICE is quite clear on this. Offer them only to children who are systemically unwell, but don't meet the admission criteria. Children at a high risk of complications, for example, if they are immunocompromised, have cystic fibrosis, or known craniofacial abnormality. Any children under 2 years old with bilateral acute otitis media. And finally, anyone at any age with otorrhea, which is a perforated eardrum. The first-line antibiotic of choice, according to the BNF, is a 5 to 7 day course of amoxicillin. If they have a penicillin allergy, consider using clarithromycin instead. Complications can be rare but life-threatening. Some extracranial complications include tympanic membrane perforation, which we've mentioned, otitis media with effusion, which can persist for weeks, mastoiditis, which is the big red flag. This is when the infection spreads to the mastoid air cells. Look for post-auricular swelling, bogginess, and erythema, which pushes the entire pinna forwards and outwards. This is a surgical emergency. Other complications can involve facial nerve palsy, meningitis, brain abscess, and sigmoid sinus thrombosis. And that's a wrap on acute otitis media. So to recap, it's a rapid onset infection, common in children due to their short horizontal eustachian tubes. The key pathogens are Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. Diagnosis is clinical, with the key sign being a red, bulging tympanic membrane. Management is analgesia first, and only give immediate antibiotics if they are systemically unwell, under 2 with bilateral acute otitis media, or have otorrhea. The first-line choice is amoxicillin. If you found this video helpful for your UKMLA revision, please like, subscribe, and let me know in the comments what topic you'd like to see next.